This is it's a rare opportunity. And it's one of those things where I don't often do webinars. I don't speak very often because I really focus on working with clients one-on-one. But what I find is that there is so much need in dentistry right now for a kind of dentistry that is not insurance-based, that is not single tooth-based, that is not grinding in the trenches day to day, but is transformational, but is making a difference in the lives of the dentist, the lives of the patients. And I am just really excited for the opportunity. So I want to thank you, Dr. Levine. I want to thank Dr. Well, there's so many people to thank here. I want to thank Denbright for putting this on. I want to thank Frontier Dental Laboratory for bringing everyone together for this event. I've worked with Frontier for well over a decade now. They are a big part and partner of the work that I do and the success that we have had in practice. And you will see some of the work that I have done with them over the years. So one of the things that we're going to talk about today is I'm going to give you guys an idea of briefly, very briefly, who I am and how I arrived at where I am in my career in dentistry. We're going to talk about the 4 keys to switching from a single tooth, grind them out, insurance-based dentist to truly doing full mouth reconstructive work and comprehensive work on a daily basis. We're going to talk about the path to prosperity in modern dentistry, because I've been at this for 27 years, and I assure you that it has changed in the time that I have been in practice. And lastly, I want to motivate everyone to be able to set a goal, make a decision, and take action on what it is that you want in your practices. Luck favors the bold, and in this day and age, it's incumbent upon us as dentists to have a mindset that overcomes our fear of what could happen if. We need to be bold, and we need to step out and learn the skills that we need to, both clinical and communication. And we really need to get passionate about dentistry again. And when we get passionate about dentistry, all of the pieces are going to fall in place, but we have to commit to excellence. So before we really dive in, I want to say a couple of things. We're going to go fast and furious today because I am going to give you a lot of information. We're going to talk about how to see dentistry in a different way. We're going to talk about how to communicate and get case acceptance in a much higher level. And we're going to talk about how to actually do significantly better dentistry. These are talks that I normally give that would be anywhere from 2 to 3 hours a piece. And we are going to try to crank this out in about an hour. So if it seems like it's coming too fast and furious, it's being recorded. And there are a lot of resources I'm going to give you at the end of this to be able to follow up on this. As a thank you to each and every one of you for showing up, I want to give you a gift, and that is a complimentary copy of my latest book. The other thing that I want to do is for all of the dentists that sign up, and I'm going to show you how to do this in just a second, that sign up to receive a copy of my latest book, one of you is going to win the Rehab Collection FMR Masterclass video series. This is a video series that has been around for a number of years. There are dentists all across the country that have taken it. It is normally it is just shy of $7,000. And we have a special offer for the people that are at this webinar. But beyond that, I want to give one of you the full video series. So before we dive in, what I want you all to do is to grab a phone and scan the QR code. And when you scan that, it'll take you to a page. You don't need to put in anything other than a name and an email address, so that we can know who the winner is. And one of you before the end of tonight will receive the full 30 modules of the Rehab video series. And it will dive deep into all of the technical aspects that I'm going to be covering tonight. It talks about airway, occlusion, case acceptance, all the above. Okay, so who the hell am I? Well, I'm a dentist, just like you all. I graduated from Marquette in 1997, and I've been in private practice for 28 years. I would consider myself a dental entrepreneur and a business owner because I've purchased 3 practices, I've started 2 from scratch, and I've sold 2. Studied with Pankey, Dawson, Rosenthal, Coyce, and probably the thing that was most impactful, I had the opportunity early on in the late 90s and early 2000s to study with Frank Spear in his practice in Seattle. And as Dr. Levine very graciously mentioned, I have completed a lot of dentistry in that time. Okay, so I have a couple of practices. The practice on the left is my practice in Denver. The practice on the right is the one in Centennial. They are both fee-for-service, and they're very much looking like what your practices would look like. The one on the left is more boutique-y. It's 3 operatories, and I have 2 employees. It's very lean, it's very mean, and we operate on about a 50% overhead. The one in Centennial is much more of a traditional practice where we have 5 employees, 6 operatories, and one is in a very high-end part of town and one is in a very blue-collar part of town. And neither of those things seem to matter in terms of the dentistry that we do. We'll talk about that. Okay, in addition to being a dentist, I'm an author, educator, but where I really get my passion is being a coach. So I began teaching live hands-on courses for other dentists and teams with PAC Live, and then later with the Calvary Center for Advanced Dental Studies. These are these classes where dentist flies in, assistant flies in, and the patient flies in, and we do a live course where we are prepping 28 teeth or a full arch, and we are completing the dentistry. That's where I kind of cut my teeth as an instructor. In 2018, I was hired by a continuing education company to create Rehab, as I mentioned, which is a video series that is designed literally step by step to consistently and predictably do FMR dentistry. I set out to essentially create a full continuum from diagnosis to treatment planning, occlusion, airway, prep, seat, everything that you would need to know about doing diagnosis, all the above, with FMR dentistry without having to leave your house and go for a week to a continuum in person, because that's just not a reality for a lot of people. And then in 2021, at the request of a colleague of mine, I became a private coach. We worked in the same office. It was one of those 70s offices where my waiting room and her waiting room were right next to one another, but the whole clinic for 3 practices were all connected in the back. It was like operatory to operatory to operatory. And one day she came up to me and she was like, I want to know what you do. I was here all week last week, you were gone. You were here one day this week or 2 days this week, and you produced more than I did. And I want to know how in the world you're doing this. And so she was my first coaching client. And I took 6 months and I said, I don't have all of my methods documented, but if you give me 6 months, I'll come back and I'll start working with you. And so we did. And 1 year later, her practice grew 50%. So why do I do this? You know, I've got 2 practices. I've got a lot going on. You know, the reason I became a coach is that I really noticed a big disconnect between what dentists learn in CE and what they actually do in their private practices. And coaching can bridge the gap and help dentists fulfill their true potential, because we all learn certain things at CE classes that we don't implement, or we want to implement, but there's a critical point and you're like, how exactly do I get the deprogrammed by NCR at the vertical that what I want? That disconnect, I can't overcome that, because it's something that I need someone to guide me with, and the person that I took the CE class from is just not here right now. So the idea is to really bridge the gap between what dentists know and what they do. So since 2021, I've coached dentists literally all across the US, like from very high-end places like Coronado Beach in San Diego to very economically depressed places like, you know, Detroit, or, you know, certain aspects and parts of Cincinnati. The average growth for a practice that I work with is 57% within 2 years of the time that I work with them. And on average, my clients earn 3 times more than what the typical dentist salary is. And I am very proud of that fact. It comes from a lot of different places on how and why those results happen. And I'm going to try to share as much of those with you today as I have time for. So as you can tell, I'm very passionate about dentistry. I am the son of a dentist. It is definitely in my blood. And it is not a big part of who I am because I believe in balance. I believe in taking time with family. That's probably my biggest priority. And having a balance of what my life looks like. I produce a lot, but it's not like I work 5 days a week or even 4 days a week. My goal and my goal for my clients is I work 12 days a month in clinical dentistry. And that feels really good because going into any year, you know that you're not working more than you're working. So I really feel strongly that it only is successful if there is a nice balance of free time and personal income while making a positive impact on our patients. So, how in the world do you make the journey from a single tooth soldier to a full mouth master? It really involves elevating skills in 4 critical ways. 1, you got to see more dentistry. You've got to be able to look at things truly comprehensively. And I know this sounds like a crazy statement, but I have yet to find a dentist that I have worked with that sees the full scope of dentistry. I just finished coaching after a year a dentist that is an AACD accredited dentist. And the biggest thing that she took away from it was seeing things differently. And we're going to talk about how that is and how that works and how to do that. We're going to talk about doing more dentistry. And the key to that, in my opinion, is studying and mastering the art of case acceptance. You know, as dentists, we are so good at clinical education. We want to know how to do the thing. But learning to communicate and learning to resonate with your patients in a way that leverages their desire or their fear to do what is in their best interest is one of the most critical things that you can do to get your patients better. We all have patients that we know they need the work in the worst way, but they don't move forward with it. Doing better dentistry, this might sound strange, but it's not about what you know, it's about what you do. Committing and mastering fundamentals of your dentistry. I mean, technology is great, and we're going to talk about that, but it's not the latest and greatest thing that's going to move the needle. It's really understanding how to look at a bite and understand which one is risky to treat and how it broke down and where it came from. And knowing with confidence, oh, this is actually related purely to the way the person bites. I can totally fix that. I have total control over that. Or, oh, this actually is something that the person does that I have no control over. How can I set up the case to not fail based upon what they are doing? How can I make it more permissive? And then the last thing, which is where coaching comes in, is really committing to self-mastery and balance in your life. Mindset is probably the biggest piece of success, not just in dentistry, but in life. And there's a lot of time that I work with my coaching clients. How do you change your mindset? What kind of mindset are you going into a consult with? How much of an impact do you think that is? How certain are you that you are going to be able to get this person well and healthy? And how certain are you that you can convince them or get them to maybe understand and step into the kind of work that you know they need? Okay. So seeing more dentistry. Okay, cases like these are literally in every single person's practice on this call right now. And I have done a lot of dentistry over the years, but there are still cases in my office. I will admit, we've done so much over the last 20 some years that there's a lot less now, and I'm having to get pretty good at marketing these days because a lot of the work on those practices that I've purchased has been done. But all of you have cases. You could probably think of names right now. Probably thinking of a person that you're like, oh my God, yeah, John, every time he comes in, he seems to fall apart more. And I've had the conversation with him, like, does any of this bother you? And he's like, no. And then he leaves and he doesn't get better. We're going to talk about how to break through with those patients. That is the majority of the people that I work with. I am not a celebrity dentist where people fly in to see me to get this shit done. I am doing this work out of a very average general practice, just like yours. And it's a totally different process of case acceptance with someone like that than someone that already knows about you, that is flying in to have you do a full mouth reconstruction. There's not a single person on this page that you see that came to me because they wanted their teeth to look better, not one. Okay, so for seeing more dentistry, if you can't see the problem, you won't plan a solution. One of the things that's fascinating about the picture that you see is this person came in as a new patient. He came in simply because he wanted me to fix the crown on number 10. He chipped it off. It was an old PFM. And he's like, I chipped this tooth. I should probably get this fixed. Many dentists had spoken to him about doing full mouth reconstruction in the past. But if you heard it in his words, and he actually has a video up on my website. If you go to, like, there's a page for rehab video, Larry is on there. But anyway, it doesn't matter for now. The idea being, he did not come in for a full mouth. And he had dentists talk with him about it before. But what he says is that the difference is that he understood through the conviction of the way I communicated with him, probably not the words, but the conviction in which I spoke, that he knew I could do the job. And he knew that I was confident in my ability to create a result for him. So you got to see the problem or you won't plan a solution. You can't present a solution if it's not planned. If you want it to be successful, you got to understand where the problem came from. Okay. So to go from single tooth to full reconstruction, there's certain things that you really need to understand. 1 is airway, 2 is occlusion, 3 is aesthetics. We all are good because we were taught how to resolve bacterial issues, decay, periodontal disease, whatever. That's dental school shit, right? Like, we all have a training in how to do that. But to really step it up, you got to really understand how the interconnection between airway, occlusion, and aesthetics all work together. All 3 of them are interrelated because it has to do with an underlying lack of space almost always. And again, I'm just going to kind of say this. This is normally a much longer, much more in-depth presentation. So like we're just going to fly. So airway, you want to learn to recognize the signs and symptoms of an underlying airway issue. When you do, it's going to open up a new world of treatment possibilities. And I'm not talking about mandibular advancement devices or anything that I would consider just a band-aid to the problem. What I'm talking about is seeing comprehensively where the problem is coming from and changing the underlying architecture that can remove the issue that what's going on. This case, this person is, as wild as it sounds, this person is 39 years old when the wear picture was taken, and he had just decimated his teeth. There's erosion, there's all sorts of envelope of parafunction issues. It's coming from airway. The lower picture that you see, it is by no means my prettiest case. In fact, it's one of the uglier cases that I've done. But the reason that I show it is there's certain things that need to be satisfied in order for the case to work. The reason the lower anterior teeth are too long is because we had to open up the bite to a certain degree to create a permissive occlusion so he didn't destroy his teeth. And I didn't want to have the uppers be too long because that's what we see aesthetically. So working all of these things into the treatment plan. So when you start to understand airway, it is going to lead to orthodontic surgery for your patients, orthodontics, restorative, full mouth reconstruction, and if you feel like doing them, I don't, but if you feel like doing them, apnea appliances. There's nothing wrong with doing them. Okay, occlusion. It's not just about recognizing the signs of occlusal problems, it's really more about understanding etiology. You know, when you look at this case, and we're going to look more deeply as far as how we quickly identify and dissect cases like this. Essentially, this case is an anterior constriction case. You can tell by the lower anterior facial wear, and you can tell that the occlusal plane is so low. Like if you look at the posterior lower left side where that gold bridge is, there is literally zero contact there. All of it is landing on the anterior teeth. So if we want to get rid of the constriction, we've got to change the way the occlusion is. But in a case like this, it's completely different than the one you saw before. This case has absolutely nothing to do with grinding. It has nothing to do with what he does with his teeth. And that's going to be one of the distinctions when we're talking occlusion. Is the wear coming from what they do with their teeth, or is it coming from the bite itself? Because that has a lot to do with predictability, and it has a lot to do with how you approach it. And then for aesthetics, and I'm going to do a shout out here, this is a case that Frontier did. It's an absolutely spectacular, I mean, I'm not, okay, yeah. I'm not saying that my dentistry is so spectacular. I think the lab work is so spectacular. This was a brutal case to do. This is someone that was during COVID. I was not doing her clear aligners. You can see some attachments on her teeth. She was wearing attachments or wearing her aligners, and she was literally living on Monster Energy drinks during COVID 24/7. And if you were to take an Explorer to her teeth, they would just come off like chalk. It was completely just destroyed. And this person was 18 years old at the time. We had two choices: take all the teeth out or do a full reconstruction. And the lab work was just exquisite. Shout out to Pedro Santos, head lab technician that I work with at Frontier Dental Laboratory. They look radiant, they look natural. They did a beautiful job. So aesthetics, while that might be the thing that your patients notice and are most aware of, it's really not the thing that that's gonna be driving the majority of the dentistry that you do. The majority of the dentistry that you do that really needs to be done are going to be more rooted in actual health problems, as this one was. And in the same way, understanding aesthetics is going to lead to orthodontic surgery, periosurgery, ortho, restorative, and full mouth reconstruction. Okay, so how do you go from a single tooth practice to a comprehensive practice? You need to have a flow chart on how you go about these things. And this slide in and of itself can be an hour-long lecture. So I cannot dive into it per se at this point in time. But what it would to say is it's either minor treatment goes one way, recare goes the other way, or if it is comprehensive, you need to have a plan on exactly how to handle that. Do you sleep screen? Is airway a part of it? Where do you go from initial consult talking about problems to actually moving towards a solution for case acceptance? Is orthodontic surgery something that's needed? Is that even something that is an option for the patient? Are they more willing to do ortho and restorative to try to change some underlying issues? Is it something that they're not willing to do ortho and it becomes a restorative thing? How are you going to manage the underlying issue if it is an apnea issue? Those things need to be decided on the front end. Okay, so regarding airway, for those of you that understand it and have studied it, that's great. For those of you that haven't, that's okay too. I would recommend giving a dive into airway. The way to discover airway problems is through questions. It's through understanding what to look for in an examination. I know a lot of people, thank God, dentistry has started to come a long way in this. You know, a lot of dentists are getting familiar with, okay, we need to look for molar width, you know, inclined teeth, scalloped tongue, palate, all of these kind of things, especially history of headgear, looking at whether or not they're retrognathic, looking at things skeletally. All of that is going to open up a world of understanding what's happening from a space perspective with their occlusion and their airway. I do sleep screenings in the office. That's the only way that I'm going to know whether there is some sort of underlying airway issue or not. And if it is positive, then I'm going to image it and find out where the problem is. It drives me crazy when we do a sleep screening and we sent it to a board certified sleep MD. We do that for all of them to get a diagnosis because as dentists, we know we can't diagnose it. And they come back and they're recommending something and all they have is a sleep screening. It's like, you don't even know where the problem is. You know, you don't even know where the issue is going on. So you've got a compromised airway, recognizing it, right? So if you do a CBCT the key measurement is what is the size of the lower airway. We want a minimum volume of 150 ideally, but minimum 150. And what's astounding is how many, when you start imaging people, how few patients actually have an airway that is that size. The other thing is, if it's an upper airway issue, it may or may not be something that we have a whole lot of control over unless the patient's willing to do some type of orthodontic surgery. So really understanding what we have control over, what we don't, and taking a bit of a deep dive into learning airway issues. Occlusion, which is probably my favorite subject in dentistry. I'm going to try to give you guys a super crash course, super quick, on how to identify where problems are coming from with occlusion. While there are many classifications and designations, in my opinion, there are really only two types of occlusion: physiologic and pathologic. And physiologic, there's going to be occlusal harmony. We're not going to have signs and symptoms. Pathologic, we're going to have all these signs and more. Now, what's interesting is there are actually two types, as I see it, of pathologic occlusion. So there's different types of wear, right? There's attrition that is tooth to tooth, but I would break that down even further. Within that, there are discrepancies within the bite, MIPCO discrepancies, and there are issues that are caused not by the bite itself, but what they do with their teeth. And those are two very different distinctions. We're going to take a quick look at that. Then we've got erosion, right? Acid coming in or acid coming out. And then we've got abrasion, tooth to substance. Okay, how do you determine the etiology of tooth wear? One of the key questions is where present in the areas where the teeth can hit. If the answer is yes, then it's some form of attrition. But I divide that very strongly, or there's a hard line between wear, tooth to tooth wear, that comes from MIPCR discrepancies and movement, envelope of function or parafunction. And then of course, erosion is a totally different issue. If you get where the teeth cannot hit, no matter what the patient does to put their teeth together, it's most likely erosion. It could be abrasion, but abrasion is very, very rare. Okay, let's dive in a little bit further and let's try to make this a little bit more tangible. So when you've got an MIPCO discrepancy, it's going to be something that is very present where the teeth hit. And then when we have envelope of function or parafunction, we're going to get where places that the teeth can hit but don't hit, typically when they bite down. It's a movement issue. And in order to achieve long-term success with full mouth reconstructions, you need to get the dental envelope of function, which is just a fancy dental word for the shape of the teeth, or in this case, the shape of the crowns or restorations, to be in harmony with what the patient wants to do with their teeth, whether that be due to grinding or due to chewing patterns. With erosion, we're getting a lot of wear in places that the teeth do not touch, tends to move around. All these things we know. Let's look at some ways to actually break down when you are in the office tomorrow. I want you to be able to see dentistry in a different way. For me, the key thing is iTero scans. It is the greatest invention for me to understand what's going on with a person's occlusion and for the patient to understand what's going on with an occlusion. And for those of you that work with Frontier, you probably already know about this. They have a sort of a gift that they give to their clients that are doing a certain level of dentistry, that they will buy you an iTero, like it's on them. And so if you are all interested in learning more about that, I would suggest that you reach out to Frontier, not just because of the whole iTero deal, but because they do an amazing job with their lab work. Okay, so let's look at some wear patterns. This is a case that I completed not long ago. We are not going to be seeing the completed case because frankly, that's not what this point is. We want to look at what's going on with the occlusion here. So let's take a look. All right, for starters, when I want to break down an occlusion, I want to look at what's it look like on models, because it's a totally different story. I start to see all the wear, I start to see everything that's going on, and I'm asking myself, is the wear in a place that the teeth hit when he's biting straight down? And the way I tell that is by looking at the scan, where it contacts, looking at the wear and where it contacts. Everything that is in contact that is wearing down, that is related to their bite. That is a bite problem. That's a CR-MIP discrepancy. Whereas all the areas that are worn that don't hit, like in this case, on the canine, on the incisal edge of the canines and on the incisal aspect of the lower anterior teeth, that is related to a movement pattern. So very quickly, you can figure out exactly which ones are risky and which ones are not. If you're changing the bite, anything that's coming from the bite problem is not risky to treat because you can fix it, you can change it. Anything that comes from what they do when they move their teeth, whether it be because of what they do when they chew or what they grind, that is something that you really have to pay attention to because it's something that you may not be able to change. Okay, aesthetics, solving aesthetic problems that really aren't aesthetic problems. Most of what we deal with, even if we call it aesthetics, really has some underlying problem. And the more we start to talk about patients about the underlying problem, ironically, the more aesthetic dentistry that we do. Both of these cases, as bad as things looked, especially the one on the right, he really was not coming to see me to get his teeth looking better. He was there simply to keep his teeth. So the more we start to talk with patients about the value and be like, oh yeah, and by the way, your teeth will look freaking amazing, you know? But that's not why we're doing it. We're doing it because your teeth need it, because things are breaking down, because things are falling apart, because there's erosion, because there's attractions, because there's all these sorts of issues. And then this thing, these two cases, exact same etiology. It's all decay, but totally different appearance. You know, is this aesthetic dentistry? Is this cosmetic dentistry? Probably not. It's probably more reconstructive dentistry, but that doesn't mean that reconstructive dentistry can't look beautiful. The reason these cases look the way they do, and the reason the case with the severe airway issues look the way they do, is because certain criteria have to be satisfied in order for the case to work. If you look at these teeth, there is really no wear related to what they do with their teeth. But on the cases that we talked about before, it all has to do with how they're moving their teeth. With these, we can make the teeth look however we want to, and it's going to be great. The wear on the two centrals on the case on the left was purely due to an accident. Okay, I mean, I'm flying as fast as I can, and I feel like I'm still slow. Okay, doing more dentistry. When I work with coaching clients individually, this is probably, they hire me to learn how to do full mouth reconstruction, but the thing that really moves the needle the most in their practice is how to do communication for case acceptance. In my opinion, it is the master skill of dentistry because it's where all of our skills come together. It can be predictable and systematic. Recognize that it is a process, not an appointment, and learning the system, concept, details, and nuanced communication to get someone to say yes is going to be the thing that makes the biggest difference in your practice. You can't do the work unless they say yes to it. So as I mentioned, when dentists work with me, while it may not be the skill initially that they are looking to master, it is ultimately the one that makes the biggest difference. And it is simply a skill. It does take patience and it does take practice. There was a coaching client that we literally spent 6 months on nothing more than scripting and verbiage on the case presentation and on the consult appointment. He had gone to all sorts of CE. He knew exactly how to do the work, but he could not get people to do it. And once that piece of the puzzle was taken care of, or that obstacle was removed for him, he was off to the races. Everyone has some obstacle. Sometimes it might be a mindset thing. Sometimes it might be a communication thing. Sometimes it's a clinical thing. But once that obstacle is removed, that's when we start to see amazing and radical growth. All right, so doing more dentistry means higher case acceptance. So the first piece of getting higher case acceptance is to know the kind of person that you're working with. And I'm gonna make it really simple. There's a million ways to try to break down what kind of person this is. Is this an engineer? Are they, do they need details? And what kind of personality type? In my opinion, you don't need any of that shit. What you need to do is you need to understand that there are two types of patients that are in your office. And almost every patient is gonna fall into these two categories. You have creators, patients who are motivated by the creation of something good, and you have avoiders, patients who are motivated by the avoidance of something bad or worse than what they have now. Okay, we all know the creators. It's a bride that wants to have her smile look gorgeous on their wedding day, or on the flip side, it's the patient that's coming in for a consult that wants their veneers redone for the third time and you're not sure you want to do it. These are the patients that most dentists are going to hear a yes from because they already have the value, the emotional appeal is strong. The challenge, of course, is do they have the confidence in you? Because oftentimes these people are going to go for 2 or 3 consults to find out who they want to do the work. But make no mistake, these are the people that get work done. Second type, the avoider. We're also really familiar with these. You guys probably have hundreds in your practice. I certainly had in mine. They've become less and less over the years as we've gotten better and better at being able to motivate them, but they're still there. I would say that the majority of our practice falls into this category. I'd say probably 70%, 60-70% of our patients, maybe even higher actually, they want to put off dental work. And they put it off until they're going to equate more pain with staying where they are than they do with getting the work done. That is the tipping point. That is the leverage point. They're the ones that need it the most, yet they go untreated and undiagnosed. It comes down to how we communicate them. If we ask them, as I mentioned earlier, do any of your teeth bother you? They're gonna be like, nah, not really. And they're like, okay, great, see you in 6 months. And the problem is that we're asking the wrong question. What we need to do is we need to use different tactics than we do with the creators, and we need to ask a different question. And the question is it important for you to keep your teeth and keep them healthy? This is like the gateway drug question to comprehensive dentistry. This is the thing that opens up the doorway to them understanding that there is a disconnect, because almost every patient is going to say, yes, they want to keep their teeth and keep them healthy. Their psychology, though, is that they perceive getting the work done as being more of a problem than where they are. They equate either the cost to it, the money to it, and they stay stuck. The basic psychology is they may not be in a great place, but at least it's a known place. To be able to get through to them, you need to get them to understand that the option of doing nothing is not an option. There's in the world, in life, there's 3 certainties: death, taxes, and dentistry. They cannot avoid it, especially people that are broken down to that degree. And if what they're trying to avoid is something worse, don't try to tell them how good their smile is going to look or how great their teeth are going to feel or all of that. They don't care. Or if they do, they still don't equate that there is enough of a leverage to be able to get them to do it. They're still thinking about the problems and the cost. You need to get them to understand that if they don't do it sooner rather than later, that it means more surgery. Single tooth implant, $7,000. Fixing a tooth is maybe $2,000. There's gonna be more cost, more dental treatment that occurs if they don't take care of the problem before it progresses. And that is the truth. All right, man, so much to talk about. Okay, this is essentially what I talked about with one of my coaching clients for 6 months. We're going to go through it in about 60 seconds. So there is a very specific process of how you go about getting this kind of person to go from having low value or little understanding to really committing and doing the work. It starts with the scan and you seeing the problem. Then it starts with not presenting what you think they need, but asking them, is it important for you to keep your teeth? Anything that you present, if you don't ask them what they want first, is going to be perceived as your own agenda, as selling them on something. You have to ask permission. Would you like to talk about the problems that I see and come back for a consultation? Instead of, well, John, I see you've got a lot of problems. I think you need to come back for a consult in a week. That's pushy, and there's going to be resistance. Ask them what their goals are and invite them to step into the next. Same thing. Once they're in the consult, are you interested in hearing about what I have to say? Would you like to know how I can help you fix this? Ask and let them step into the next phase of what you can do for them. Don't give a ton of treatment plans. In fact, I suggest walking into an initial consult with no treatment plan whatsoever. Talk with them about what they want. Oftentimes the plan will be more comprehensive and more complete and better than what you would do if you're sitting down on your own, because you're like, well, I don't know, what do they want to do? Do they want to do ortho? Do they not want to do ortho? Would they want to do orthodontic surgery? You can't answer any of these questions, so don't have it written down. Just come in, be a facilitator, and be open, and you will be blown away by what happens. But when you present a fee, make sure that you've asked them if they want it and if they want to see it and if they're interested in getting it taken care of, and present the full fee and the best treatment. Last step, if you're going to overcome obstacles, you want to do it by identifying barriers. If they say, oh, I don't know, doc, I'm not sure if I can do this right now. And I'm just like, okay, well, call me when you want to. Help them. We're in the business of helping people. We're not selling cigarettes here. We are trying to motivate people to get the work done that they badly need. And so be in service to them, stay with them. I understand that you may not be, I understand that it's not something that you feel like you can do at this time. What is it that is the barrier from doing it? Do you, is it something that's a time issue? Is it a cost issue? Is it something that you're dealing with in your life? What is it that's the thing that is keeping you from doing what you said you wanted, because you said you wanted to keep your teeth and keep them healthy, and I want to be able to help you that. I want to help you through the barrier. Be an advocate for them. Be on their team. Work on it together. So regarding improving case acceptance and communication, as I mentioned, asking patients about their goals before you do anything else, it really helps to frame the entire conversation in a way that is for their benefit. Also asking consent. If you'd like to learn about what's going on with your teeth and dental health, I'm happy to set aside time and chat about it. It's totally up to you. Is it something that you'd like to do? You just ask enough people that eventually you're going to have so many people that are saying yes to it. It's like if someone says no, it's like it matters only to the degree that you want people to get healthy. It doesn't matter to the degree that they're going to walk away. My definition of a successful initial consultation is that you tell the person the full scope of what's going on. You show them, and they come back to your office. That's it. You don't have to get a yes. What you want to do is be an advocate to them so that they come back 6 months later and 6 months later and 6 months later. And you have an opportunity to elevate their value, to elevate their awareness. They will eventually do it. Just assume with every consult that you walk into ever, this is a mindset thing, that they're going to do it eventually. Like I said, dentistry is an eventuality. It's not an if. It's just a when. And don't think of it as a single appointment. Give yourself an opportunity to have multiple conversations with them. If you don't want to try to sell someone on anything that they can't tangibly understand. You want to be able to have them step into something that they want, not sell them on something that you think they need. You want to be able to show them what they're buying as well. It's like test driving a car. There's amazing ways to do it. You can use digital scanning and exocad. You can do an in-the-mouth mock-up and show them and take pictures. You can do a wax-up. There's all sorts of things. But before you just walk in and give them a $60,000 treatment plan for a full mouth, I want them to tangibly see where their teeth are starting from and where they're going to end up so they can have some understanding of what they're buying. And when you're communicating, recommend that, and even right now, I mean, obviously you can't see me, but you hear my words, but it's the tone of voice, it's the commitment, and it is the passion that is going to resonate with you or not. And it's the same idea with your patients. If you truly value it, you really believe in it, you believe in your skills, you believe in yourself, and you believe that you're doing the best for those people, it is going to come through in your case acceptance. And while words are the least important thing, it does matter. You know, it's more inflection, it's body language, it's all of these things, but words do make a difference. If I'm going to say to a patient investment versus cost, that's going to resonate differently, and health versus treatment. So certain words you want to get in the habit of using, and replacing cost with investment is a key one of those. Okay, God, we are just flying here. Okay, doing better dentistry. Oh boy, okay. Well, for starters, there is an 18-hour video series on what I'm going to try to talk about in about 8 minutes. So let's be clear. I'm not going to cover everything, but I'm going to walk you through one case. Sometimes, you know, pictures are worth 1,000 words, but the key pieces to achieving better dentistry and going comprehensive is understanding the etiology of a problem before you plan it. It seems obvious, but I can't tell you how many coaching clients that I'll initially get on a call with, and we're working through a case. Like, all right, I'm really excited. We're going to do this full mouth reconstruction, or I want to try to do my first one or my 5th one or whatever. And they're like, okay, I think we should do this. I think we should maybe like open the bite here, or we should do crowns on this. And I'm like, okay, what is the problem? What led them here? And unless you know that, you really understand the etiology, you're at risk of not being able to resolve the underlying issue and perpetuate it. And I know this from experience on early cases that I did that train wrecked. Okay. Other thing is, you need to have a deep understanding of the basics of quality dentistry. I'm not talking about wild and elaborate planning. I'm talking about understanding the fundamentals of occlusion, the fundamentals of taking a great impression, the fundamentals of being able to prep beautifully. It sounds boring and it sounds basic, but really having a deep understanding, and that only comes from practicing it, from doing it, not from going to classes and learning about it. At some point in time, you got to just jump out of the airplane with a parachute and go for it. You know, for a lot of people, they go through that process on their own, and for a lot of dentists, they want to work with someone to be able to do that, to be able to not have maybe as many challenges along the way. Get a specific, tested, well-proven protocol for all you do. Do it the same way every time. Keep it as simple as you can. Don't cut corners. Having limited but tested and very carefully selected palette of materials that you use for any given procedure, and the fewer materials, the more consistent the results you're going to get. Do everything as conservatively as you can, but not at the expense of longevity. When sometimes people talk about biomimetics, I start to cringe a little bit, because I see these cases where they are taking out huge fillings and they're leaving like this little spicule of cusp that's there. I'm not talking conservatism just for the sake of being conservative. You have to restore the tooth. And when I say restore it, I'm talking about the strength of the tooth to begin with, the structural integrity, but be as conservative as you can with doing that. And then finally, don't aim for perfection. Aim for consistently good, then consistently great, and then for excellent, but always aim for consistency. Okay, we really honestly don't have time to run through how we go through these cases. I think all of you probably are familiar with how to set up a case, whether it be Smile Design or FMR. You know, records create a result that you want, whether it be a wax up, a digital design, whatever. Get them numb, prep it. You're going to build it up. We're going to look at all of this. You're going to provisionalize it. You're going to provisionalize the bite to be able to get the records, all of the above. You're going to scan it and you're going to cement it. Yeah, sure. Sounds super simple, right? Yeah, that's all you have. That's all there is to it. Yeah, obviously it's a lot more than that. but let's just dive into a case and then maybe it'll, become a little bit more clear. All right, so this is Gerard. Gerard came to me because I bought a practice. This patient had been in the practice for 20 years, and he had been hanging out looking just like this. And the dentist that I purchased this practice from was an excellent dentist. He was in my Spear Study Club, and he had all the right answers. And when I bought his practice, I really didn't think that there'd be much dentistry to do. And I was wrong, because the difference between what we do or what we know and what we do for dentists can be vast. And so Gerard had been hanging out in his practice for a long time. And as you can see, we have a myriad of things going on. We have attrition and we have a ton of erosion. And so one of the things that's interesting is when you have both, how did it happen? And why is there both going on? If attrition is active, why isn't it flattened? If erosion is going on, why is it cupped? So in this case, he had a severe airway issue, but it wasn't a lower airway issue. And he was grinding his teeth like crazy long before I saw him as a patient. And then he had surgery for a deviated septum redone, and he could breathe beautifully, and his grinding stopped. But what didn't stop was the wear, and it became wear related to erosion, because he had all these windows of dentin that had been opened up, and he had had a gastric reflux issue going on. So when, this is a tip, when the wear, meaning the attrition, the tooth-to-tooth grinding, is not keeping up with erosion, it means that the grinding has slowed down or potentially stopped. That is a much more safe case to be able to treat, because they're not actively grinding. And erosion is a very predictable thing to be able to treat long term. Don't have time to get into all of the reasons why this is the case. Okay, there's lots of reasons, or lots of ways, excuse me, to decide where you want vertical to be. I like to use deprogrammers. My bias is a Kois deprogrammer. I had a Kois deprogrammer in, sorry, I don't have photo of it. I bonded composite to be able to hold the vertical where I wanted it to be, but then I trimmed it down to get the proper opening. As you can see on the upper one, it's open much higher than what we necessarily need it to be. So I kind of dialed that in, equilibrated that into the vertical, then we took our bite. Okay, I'm a big believer in having a very specific protocol with buildups and composites that you do every time, absolutely, without question, without fail. I've been doing this method of buildups and this method of bonding for, oh my God, like 18 years. I don't know what it would take to get me to change right now. Of the work that we do, our sensitivity is almost non-existent, and we have, we work on a lot of teeth that are really, really beat up and really destroyed. And the incidence of endo in our practice it's so rare. It's far, far less than 1% of the teeth that we do buildups and crowns on. And I attribute that to not only the materials, but more importantly, partly the materials, but also the way in which we go about it with the technique. There's no air water syringe, it's only high-speed suction. We don't want to impart any water, any impurities, anything like that. Multiple layers of bond and primer. Again, not enough time to go into it all here, but if there are things that I can do to help any of you that are out there listening to this, whether it be through the video series or whether you want to reach out personally or whatever, I would love to connect. So here's upper arch built up. Here's preps. I'm a big fan of the KS series of burrs, but I've changed some things. This is like a case that I did back in 2018. I like to believe that I'm getting better as a clinician as I'm getting older. I'm 55 at this point in time, and so one of the changes that I made between the preps of old and the preps of new is I'm using some very fine grit diamonds that are very wide to finish the preps. With crowns, it just looks cool. I mean, it doesn't necessarily matter as much, but man, with veneers, getting things that smooth to see them, it's a game changer. So you want to confirm adequate space. You guys are probably familiar with how to do that. I personally like making a set of temporaries to be able to confirm space because it's in all 3 dimensions. And if we look at this, you can tell the matrix is not really seated properly on the right side because there's way more room than we need on those lower anteriors. Best way to confirm room is to make a set of temporaries. I'm going to show that in a minute. I'm pretty old school. I used to say, if you're going to press the restoration, impress the teeth. But at this point in time, I don't necessarily think that that is the case. Scanning has come so far. We're doing a lot of cases with scans that are multiple units, even full arch. I think it's just whatever is best in your laboratory technician's hands, what they like. If I do impressions, I do a tri-layer technique where we're using a kind of a strong or heavy Siltec putty with heavy body and with light body as well. And as you can see, it just sort of injection pressure molds the light body into the sulcus. Okay, we're making temps. We use Luxatemp with a matrix. This is a great way to be able to see what you have in terms of reduction. I like making a set that might be a throwaway temp, might not. Clearly, this is not a throwaway, but you can evaluate from facial to lingual to incisal exactly the space that you have. I'm a big believer in dialing in the bite and the vertical with my temporaries. And I know we all know, like, yada, yada, yada. Yes, I know lingual cusp for uppers, central fossa for lowers, but I'm not sure dentists really, based upon what the work that I have done with dentists, that they really understand that, like, quite literally, that is the only places that you want contacts. You don't want any inclined contacts. You don't want any contacts other than exactly where you want it to be. And theoretically, sure, it makes sense. But the challenge is actually creating that in the mouth. When you're doing a full upper and a full over, getting that occlusion to really dial in that way. So I use temps to be able to set my vertical. I'm going to have a set on one side. We're going to take a bite impression on, like, let's say the left, for example. In this case, all the rest of the temps are in. I let that set, pull it out on the right side, do a bite on that, let that set. Then I pull out the anteriors and we do the front. So then we have a bite registration in all dimensions. Here is the set of temps in this case. And yeah, I think the case turned out all right. I mean, it was a really challenging one. I think the porcelain work looks very natural. And the biggest piece about this is for someone that has decimated his teeth, you know, it's 2025 right now. We did this case in 2018, and I don't have a follow-up at the moment. I will post that on my Insta at some point in time, but we have not had a change. He has not had a single tooth that's been lost, and restorations are holding up beautifully. Okay, last piece, as we talked about, is success mindset. The way I see it, the path to prosperity in dentistry involves ambition to do better for yourself, for your patients, and for your family. That's really where it starts. Then vision, which we talked about today, is recognizing a wider existence of problems and taking a comprehensive approach. Having wisdom, which is going to come from experience. It's going to come from doing this kind of work, not just theoretically having an understanding of conceptually how it might work, but doing it regularly and taking action on that. From that wisdom comes confidence. If you have done a lot of this work and you know before you ever start the case that the result is going to be successful, that is a completely different way of communicating with your patients. It comes through, and the difference in case acceptance is remarkable. And obviously the benefits, you know, when I'm coaching with someone, it's not to work harder. You know, my goal is to have people work far less and make far more. You know, it's like, who wants to work more and do it? Dentistry is hard, like really hard. So, you know, if you can produce 50,000, 40,000, even 20,000 in a day, you know, do you want to just keep grinding that out day or do you want to take some more time off? I feel like that there's something more to life. And if I can produce in a day what I would normally produce in a week, that's why I take 1 week off a month. I said I work 12 days a month, but it's 4 days a week, and I take 1 week off per month because that's just kind of what juices me. That's what gives me the energy and the passion when I go into the office to be at my best. So I want to encourage every single one of you to set a goal and make a decision to do something. Do something in your practice, do something with your education, do something to better yourself personally, professionally. This picture was taken at a coaching retreat that I hosted in Cabo. Gosh, it's hard to believe that was just last year. It's a restaurant called, I'm not sure it's pronounced Acre or Acre, but we did this coaching retreat, and everyone brought cases, and it was just a fabulous experience. But every single one of these people are taking action towards what they want in their practice and in their life. In fact, the people that are closest to you, I'm not sure if he is on the call, but Jason and Katie, I worked with them recently to transition out of corporate dentistry. That's one of my biggest passions, is taking dentists that are either associates or involved in corporate that want to make the leap into private practice ownership, but they want to do it in an intentional way. You know, I've done it multiple times myself. I've helped many clients do it. And Jason and Katie, they're actually in Denver. Like it was wonderful to be able to work close by. I mean, we'd meet for coffee and we'd chat and we'd do coaching meetings that way. But they found a practice. I helped them analyze it, help them analyze the prospectus, figure out which practice is a good one to buy. They bought it for $500,000. The practice was doing $700,000. End of first year, they did 1.5, and they're on pace this year to do 1.9. That is huge leverage. And this is possible for many people. Jason is an amazing person, and he's an excellent dentist, but it's not like he has some crazy skill set that all of you that are watching this don't have, you know. And maybe all of you are practice owners out there, I don't know, and maybe you just want to up level the practice that you're in. We do a lot of that as well. But maybe some of you are wanting to take your situation and change it into something that is more and that is greater and that has more autonomy. So, you know, I would challenge you. Where are you now in your life and your dental career, and where do you want to go? If you can do it on your own, fuck yeah, more power to you. Go for it. And if you would like to find someone that has done it and work with someone, you're going to get there faster. There's no doubt about that. And there's going to be a lot of confidence that comes from working with someone, whether it's me or somebody else that has done it before for themselves, for other people. You know, life is short, and luck is going to be on your side if you take bold action, whatever that looks like for you.